بسم الله الرحمن الرحيم. Assalamu alaikum. The subject of today will be about specific types of neonatal infections. There are some types of neonatal infections like in the skin infection involving the eye infection, conjunctivitis. This is necrotizing enterocolitis of the bowel, and this is pneumonia. There are other types, but today we will concentrate on these types of infections. Starting talking about the problem of necrotizing enterocolitis, which is a serious illness that is associated with prematurity, and it is seen mostly in first few weeks of life because the bowel of this preterm is vulnerable to ischemic injury, then bacterial invasion. And one of the important predisposing factor for this problem is starting with the cow's milk formula, but adding pre and probiotics to this formula may decrease the chance of this problem. This is picture showed to us the site of this infection: inflamed bowel and inflammation of the mucosa. The neonate will present with feeding intolerance, vomiting, and this vomiting may be bile stained. Other clinical manifestation: they may develop abdominal distension, they pass stool containing fresh blood. Also, the infant may rapidly become shocked and may require mechanical ventilation because of huge abdominal distension and pain. And there is characteristic radiological findings when taking plain abdomen. And some of these neonates may complicate with occurrence of bowel perforation. And this is picture of a neonate complaining of necrotizing enterocolitis. You can see this is a huge abdominal distension, is gross and very clear, and the skin is tense and shiny. The veins under the skin are clear, very clear, and there is a characteristic feature of the X-ray of the abdomen. This is air under diaphragm from bowel perforation. This is air in portal tract, and this is dilated bowel all over the abdomen, and sometimes intramural air. There are many predisposing factors behind this condition, and most of these neonates, nearly 90%, are premature, especially when they are exposed to hypoxia, like our respiratory distress syndrome or pneumonia, because hypoxia will lead to ischemia of the bowel. Also, if they need umbilical catheterization, exchange transfusion, which need again umbilical catheterization, polycythemia is also a predisposing factor. And when we start rapid onset of enteral feeding and increase this amount in short period, this will lead to this problem. And this picture shows to us some of these predisposing factors. This neonate need umbilical catheter. This is set of exchange transfusion. This is premature baby was lying in the incubator, and this is a neonate with bottle feeding. The precise rule by bacteria remains uncertain, but it is caused also by infection of this ischemic bowel. And the organisms responsible for these infections are many, like E. coli, Klebsiella, Clostridium species, and Pseudomonas. Regarding treatment of this condition, we need to stop oral feeding and add broad spectrum antibiotics. We need to cover aerobic and anaerobic organisms. Because we stop oral feeding, we need parenteral nutrition, and because they may have shock and apnea, they need mechanical ventilation and circulatory support. And when they develop bowel perforation, definitely surgery is needed in this condition. The prognosis or outcome of this condition, this disease is associated with significant morbidity and also mortality, which reach 20%. And if the baby survive, he may complain of long-term sequelae, like development of strictures and malabsorption, especially when he need bowel restriction. And also he may develop poor neurodevelopmental outcome. Let's to hear this case scenario. 14 days old infant female born to 24 years old mother, gravida 1, para 1. This baby was born at 32 weeks of gestation. The type of delivery is spontaneous vaginal delivery. Birth weight is 1.3 kg. She was admitted immediately after delivery because of respiratory distress syndrome. Then, nutritional needs have been made by enteral feedings of preterm formula, supplemented with parenteral feeding also, which was stopped 1 day ago. And the amount of feeding is 30 cc every 3 hours enterally. It means by mouth. This infant now is presented with the clinical features now become abdominal distension. She had developed vomiting, bilious vomiting, and pass fresh blood in the stool, and there is decrease in urine output. On examination of this neonate, temperature 36 degrees centigrade, the heart rate is 180 beats per minute, the respiratory rate is 60 breaths per minute, blood pressure 63/40 millimeter mercury. On examination, in general look, she looks lethargic, toxic, poorly perfused. On examination of the heart, there is tachycardia, obvious tachycardia, but the lungs are clear. Examination of the abdomen had revealed tympanic abdomen, distended abdomen, hypoactive bowel sound. So after hearing this scenario, what do you think this neonate have and why? Let's to answer this problem. From history, from examination, we can conclude that the diagnosis is necrotizing enterocolitis, and from history there are many predisposing factors for this problem, like very low birth weight. The birth weight was below 1.5 kg. She was born to 34 weeks of gestation. It means she is premature. She started preterm formula and 30 ounce, 30 ml per feed, and this is rapid increment in her oral feeding. What is the investigation we need to do to confirm the diagnosis? A simple and available one. We can do plain X-ray, and we can know the findings of the abdominal plain abdomen by X-ray, significant bowel distension. And also in this X-ray there is a clear distension of the bowel, edema of bowel wall, and nematosis intestinali. This is especially here in this area, air in the abdominal, in the wall of the intestine. and sometimes may have perforation. So, what is the treatment for this condition? What is the treatment of necrotizing enterocolitis? First, we need to withdrawal of oral feeding. We will need to do gastric section. Start intravenous fluid, start parenteral nutrition, and give antibiotics. We mentioned that antibiotics should cover aerobic and anaerobic, so we give ampicillin, gentamicin, and metronidazole. What is the course of this antibiotic? 7 to 10 days. We will talk now about other common infections, what we call it focal infections. And the most common one is conjunctivitis, or what we call it ophthalmia neonatorum. Look to the eyes of this neonate. There is purulent discharge from the eyes. There are many bacteria or many agents are responsible for occurrence of ophthalmia neonatorum, like chemical conjunctivitis, Neisseria gonorrhea, Chlamydia trachomatis, and other pathogens like Staphylococcus aureus, Streptococcus pneumoniae, and herpes also may cause conjunctivitis. Let's talk first about chemical conjunctivitis, which is present with watery discharge, not purulent, watery discharge thin from the eyes due to use of silver nitrate, sometimes erythromycin or tetracycline. We can use povidone, iodine 2.5% ophthalmic solution for ideal prophylaxis of this condition. The most important bacteria causing conjunctivitis is Neisseria gonorrhea, because it is associated with complications. Some of these complications are local in the eye, like corneal perforation, and sometimes the complications are systemic, like sepsis, meningitis, and sometimes septic arthritis may occur. So in the presence of Neisseria gonorrhea, we need to treat systemic treatment, not only local treatment. And in systemic treatment, we use ceftriaxone, third generation cephalosporin, 25 to 50 milligram per kg once per day. And the course is 14 days, especially if the signs of systemic manifestations are present. Sometimes we can use penicillin intravenously. Of course, need irrigation with saline solution for the eye, and local eye drops, penicillin eye drops. Another bacteria which can cause conjunctivitis is Chlamydia trachomatis, which is the most common neonatal conjunctivitis. Neisseria is more serious. This is most common, and but it may be associated with some complications like upper respiratory infection or pneumonitis. And it is treated with erythromycin systemic, 50 milligram per kg per day orally for 14 days. And also it needs local eye drops, erythromycin eye drops. How to diagnose conjunctivitis? From clinical history, there is discharge from the eye. We can take this discharge for culture and sensitivity. And for suspected chlamydial conjunctivitis, we can use GIMSA stain, which shows intracytoplasmic basophilic inclusions. There are other methods of diagnosis like ELISA and PCR. Other focal infections in the neonate is focal skin infections like napkin dermatitis, cellulitis, pustulosis, and omphalitis. And the skin, these skin cellulitis, pustulosis, and omphalitis caused by Staphylococcus aureus. Napkin dermatitis, a combination factor. Let's see, this is a slide showing This is diaper rash, napkin dermatitis, which is super added by it. It is irritation from stool, from urine, but infection with candida can occur in this region. They need frequent diaper change, avoid contamination by urine or feces. They need zinc cream and also topical steroid with antifungal treatment. This is another slide of napkin dermatitis. Although napkin dermatitis is common from 3 months and above, but can occur in neonatal period. And this is a picture of a female neonate 3 weeks of age has napkin dermatitis. You can see this what we call satellite lesions, like moon, like round in shape. This is super added candidal dermatitis, but it is successfully treated with nystatin ointment. Again, this is napkin dermatitis, but added by bacterial infection, super added. There are papules and plaques in the diaper region. Other than napkin dermatitis, the neonate may get infections in other parts of the skin, and this is the pustules around the umbilicus in the abdomen. We can see here another slide. These are different areas, hand, feet, involved by pustules, and this is pustular skin rash. This is caused by bacterial infection. We should differentiate it from a benign condition called erythema toxicum neonatorum, which is a red spot on the skin, overlying papules or pustules, and sometimes few and sometimes are diffuse, sometimes like patches. And these are benign conditions and cause no discomfort to the baby. This is not a skin infection. One of the important type of infection in the neonate is pneumonia. The typical presentation is indistinguishable from sepsis. The infant is presented with respiratory distress, tachypnea and dyspnea, and again this finding can be found in septicemia. And the antibiotics for this condition is similar to that used for sepsis. The neonate either presented in the early neonatal period in the first week of life with respiratory distress, sometimes in the late neonatal period, especially when the neonate is in need for ventilator or oxygen dependent, he may develop bronchopulmonary dysplasia. And most neonatal pneumonias are diffuse, bilateral. This is picture showing to us bilateral involvement of the lung. Again, this is another picture show to us bilateral involvement of lung by infection. Another important infection in the neonate is urinary tract infection, which may occur due to or may cause bacteremia. Sometimes bacteremia predisposed to UTI, sometimes UTI lead to bacteremia. And it is caused by gram-negative enterococci. It is higher in male infants in the neonatal period, diagnosed by urinalysis or urine culture, and the culture in this age group is obtained from suprapubic aspiration or by catheterization. In the absence of other systemic disease, a UTI is treated with antibiotics for 7 to 14 days, and they need renal ultrasound to rule out anatomic causes of urinary tract infection. and if it occurs more than one, voiding cystourethrogram is needed and should be performed if renal ultrasound shows structural abnormality. Other type of infections that may occur in the neonatal period is omphalitis, which is either localized or spread. Omphalitis infections of the umbilical stump may spread to abdominal wall, peritoneum, umbilical vessels, portal vessels, or also may spread to the liver. When it spread, it may cause abdominal wall cellulitis, necrotizing fasciitis, and extrahepatic portal hypertension if the portal phlebitis occur. Clinically, there is erythema around the region of umbilicus. It may be associated with sepsis and hepatitis. And of course, it needs antibiotic therapy with agents against the staph and against E. coli. And sometimes surgical incision is needed if the abscess is formed. And this is a picture of umbilical infection complicated by abdominal wall cellulitis. Thank you very much for your listening.